One of the things breast cancer patients are most concerned with is reoccurrence and concerns of breast cancer becoming metastatic. Because we've come so far in our research, I felt that it was really important that we have someone like Dr. Kevin Cheung with us today because it really brings us hope. And as a two-time breast cancer survivor, I have to tell you, I don't use that word hope lightly. Dr. Cheung is Associate Professor of Public Health Sciences Division and Associate Professor of Human Biology Division at Fred Hutch Cancer Center. He received his BA from Harvard College, attended medical school at Weill Cornell Medical College, did his internal medicine residency at Brigham and Women's Hospital, and a medical oncology fellowship at Johns Hopkins. Through his collective lens, Dr. Cheung and his team aim to discover more effective treatments and prevention strategies for metastatic breast cancer. Please help me welcome to the podium, Dr. Kevin Cheung.
Well, great. Thanks, Terry, for the invitation to speak here, and thanks for their nice introduction. And really glad to see some familiar faces and meet new friends. As Terry mentioned, I'm a medical oncologist by training. I mostly run a lab these days, focused on finding a cure for metastatic breast cancer and thinking about better ways to treat and prevent it. And what I thought about with this conference, which is really, focused on I would say a really early point in a woman's journey, a patient's journey through the breast cancer diagnosis, is really to help empower them, empower the audience, empower our listeners to think about, like, putting in context what is a huge amount of decision-making thought process going into decisions about treatments, about cosmetics, and with an eye towards obviously this thing that we're all concerned about, which is metastatic breast cancer. And to put us all on the same page, what is metastatic breast cancer? Well, we know that breast cancer cells, they start in the cells of the breast, and these cells form a mass called the primary tumor. And breast cancer that has metastasized to other parts of the body, it's still called breast cancer, and it's different from cancer that starts in other parts of the body. The breast cancer retains a memory wherever it goes. Okay, so just keeping that on the as a framework. And the important thing is that I think, as we know, metastatic cancer for the vast majority of patients is treatable, but most often not curable. There are really exciting approaches, immunotherapy, target therapies that have benefited patients, and they're living their lives even with metastatic disease. But for many patients, it's treatable but not curable. And this is why this is absolutely a problem that we're focusing on, that many in the field are focusing on. Now, the goals of today's talk really at the core is to review foundational concepts in metastatic breast cancer research. And as a medical oncologist and as a cancer biologist, I want to be able to connect what laboratory scientists have been studying for the last 100 years. There are like 500,000 publications on metastatic cancer. I'm not going to go over all of them, but at the same time, these concepts have influenced the cancer treatment, the surgical decisions, radiation, cosmetics, thinking about ways to sort of monitor cancer and risk of recurrence. These are all connected. And what I want to do today's talk is provide someone and empower them to understand the big picture as they make decisions. This is going to lead to some general recommendations regarding metastasis prevention. And with the time remaining, I'll talk a little bit about some of the work we're doing in our lab to understand how breast cancers turn out to cooperate with one another to form metastases, and approaches we're developing to stop this process. Now, the foundational ideas around metastasis is there are 3 steps. There's local invasion of cancer cells into the surrounding tissue. There's dissemination of those cancer cells into the bloodstream, and those cells have to then colonize distant organs. Now, we recently published a Nature's review on this, welcome to read it. But the main notion here is that cancer cells have to break through the fences that normally keep them from escaping into the surrounding tissue. And this is why margins are so important, because the cells at the edge of the tumor are invading into the blood vessels, into the surrounding tissue, breaking it down. In that process, they involve and recruit a variety of normal cells And that's something that many of us in the field think is absolutely important. And that allows them in some way to then gain access into the blood vessels and the lymphatics, which of course you'll be hearing about later today, and gain access into the circulation and reach distant organs. At that point, those cells are under immense stress from the immune system, from basically cell death mechanisms such as apoptosis, oxidative stress, shear stress. And those few cells that survive, many of them do not go on to form metastases. But in the small fraction that do, they then are able to grow, and over a long period of time that we haven't fully sorted out yet in the field, they form metastases that you can affect patients clinically and that lead to metastatic cancer. The key here is that the probability of achieving each of these steps is decreasing over the stages. You think about this Swiss cheese model of complex systems that determine whether you have a sort of a medical error in the hospital or like you have an issue with a plane crash. The probability of metastasis depends on a combination of the probability of invasion, dissemination, and colonization, with the most unlikely of steps being colonization, the most common of those steps being invasion. And that's how we think about treatment, because the point of treatment is to stop this process. After a primary tumor resection, surgery, mastectomy, lumpectomy, this process is stopped. But residual cancer cells can persist, and they can give rise to either local recurrences, which will require further surgery, radiation, or systemic therapy, or distant recurrences to organs outside the breast, and that is metastasis, absolutely requiring systemic therapy. Now, one of the fundamentals I want to get across to this audience is the main problem we have today, and still a problem in 2025, is the limit of cancer cell detection. Cancer cells are seeding at between 1 to, let's say, 10 cells, giving rise to a future metastasis. But the CT scan detection limit is about 0.3 centimeters, which is about 3 million cells. We're talking about millions of cells by the time you can see it on a radiologic scan. And by the time it's palpable, or by the time it's causing symptoms for a patient, we're talking about billions of cancer cells. So we are catching cancer when it recurs very late in the process of its evolution and adaptation to the distant environment. And this is why treatment, you say, well, is it all gone? And the physicians can't necessarily say with 100% confidence. It's because of this issue. You can imagine here on the x-axis being the day from diagnosis, tumor burden on the y-axis. With surgery, you're taking it down to a point where you can't detect it anymore, but there can still be cancer cells. Now, there's two possibilities. There's residual cancer, or there's no cancer left at all. With chemotherapy, with treatment, we can bring down endocrine therapy, bring that down to no cancer left. You don't know that because you can't see it, but our expectation is that treatment will reduce that risk. If down the line, 5, 10, 15 years down the line, you see metastasis, it tells you that those cancer cells have persisted. And this is the fundamental issue. I think that in an area of technology is that if we can bring down our ability to detect cancer to lower amounts, such as with circulating tumor cells, cell-free DNA, a variety of these other tests, theranostics, other things I'll talk about, that could be transformative for how we treat breast cancer patients. Now, we also know that metastasis can emerge late after diagnosis. And in ER-positive breast cancer, which is about 70% of women and patients diagnosed with breast cancer, you know, this is one of the largest sort of cohorts, early breast cancer trial is sort of assembled a New England Journal of Medicine paper. And the point here is that there's this cumulative risk that can extend out to 20 years of sort of accumulated risk of breast cancer. I just want to highlight, of course, this is from data from, dating back to the 90s up to now. And we now know that, with our sort of better treatment, better sort of systems in place for how we approach different types of cancer subtypes, we have about 20-25% recurrence rates than what's shown here. But that's a key point. The other point I want to make is that breast cancer subtype absolutely is important when thinking about the timing of metastasis, the likelihood of where it's going to spread, and it's the importance of therapy. we know, to this audience, as you know, there's different subtypes like estrogen receptor positive, HER2 positive, triple negative. This diagram shown here just emphasizes that the likelihood of metastasis is and the tempo of metastasis is very different between triple negative, which tends to happen in the first 5 years, and ER positive and other types, which tend to extend out over a longer period of time, but at a lower frequency. Likewise, when we think about where breast cancer goes to, oftentimes ER positive tends to go to the bone. Brain metastasis are more often with triple negative or with HER2 positive disease. Sometimes we see metastases to the intestinal tract. We're thinking about lobular breast cancer. So depending on one's cancer subtype, you would want to be thinking ahead to, well, where is it going to arise? It may not be the same. It's going to be different for each patient. And so the main idea I want to get across here is that breast cancer treatment and metastasis is not one size fits all. And in 2025, it's absolutely key to understand the molecular profile, not just tumor subtype of HER2 triple negative, but also variety of immune markers, microsatellite instability, sort of germline things like BRCA1, 2, and other mutational markers. And this tumor subtype, this molecular subtype, is what dictates adjuvant therapy. I'm not going to go into this to the sort of complex flow chart that but it's a very, very deep flow chart of, depending on where you sit in these different receptor subtypes, there's going to be a different set of treatments that are appropriate. But I think that this also, as Dr. Consorti mentioned, neoadjuvant therapy is something that is increasingly being adopted in many settings. So neoadjuvant therapy, as you know, it's a treatment before surgery. And in light of this issue of this limited detection problem, if you can't see the tumor, you don't know if it's going to respond. But in the neoadjuvant setting, we can treat the tumor, let's say with HER2 targeted therapy in a patient with HER2 positive breast cancer. If we see a great response, it gives us positive feedback, positive information that indeed this thing is responding. If we don't see a response, we know we have to change tack. But it's in the context when the tumor is measurable. And I think this is where we are today, is we're looking at better approaches with neoadjuvant therapy for both escalation in the case of treatment failure, as well as de-escalation. We may need less treatment. Maybe we'll even need less surgery or less radiation while using this piece of information. Now, the other piece is that biopsies are absolutely important. And so a biopsy is a removal of a sample of tissue from your body for testing. And a pathologist examines the biopsy for cancer and writes this pathology report. It's quite complex. Since breast cancer can change over time, when we're thinking about not just a point in time, but over time with these types of neoadjuvant or adjuvant treatments over a decade, let's say, when you see an emergence of cancer, a repeat biopsy is absolutely essential for the reason I just mentioned, that it is not one size fits all. And it is absolutely important to understand that molecular profile of the guide treatment. In fact, for some treatments for some patients I've taken care of, you can actually see changes from, let's say, HER2 negative, HER2 positive. A patient can have a situation where they are not going to have an option, and then they have an option later on. So it is very valuable to taking these biopsies. And in terms of an empowerment for the patient, I think it's really important to read through that pathology report and ask whether was this a good test. There are settings when we get biopsies, let's say the tissue is in very poor condition, the pathologist will say in the report that they're not certain that they're really confident in this result. Talk to your physician, see whether another biopsy is indicated, because this decision about treatment is guided by these biopsies. Now, there is hope moving forward for improving metastatic cancer detection and prevention. There's a variety of blood tests sort of entering clinical practice and also in clinical trials, looking at tumor shedding of circulating tumor cells, cell-free DNA, cell-free RNAs, exosomes, a variety of things that are shed from the tumor cells themselves and can provide a clue that is operating at below this sort of radiographic detection limit, as well as imaging tests, molecular tracers such as fluoroestradiol, which is kind of like it's kind of like PET CT scans, but instead we're looking at sort of detection of cells taking up estrogen. There are a variety of theranostics people are developing, which are basically antibody and other device-based tracers that let you hone in on on where the tumor is located. Still today, I think that, some numbers would estimate about 100,000 or more cells are required to detect cancer using, cancer has to be at least 100,000 cells or more for you to detect, have a positive test with one of these molecular biology tests. So it's still, we're not at the point of finding, discovering cancer cells at the earliest stages, but we're getting better. Some Fred Hutch studies, that I just want to highlight. So Duet is run by my colleagues Cyrus Kajar and Chris Lee. They're looking at sort of bone marrow disseminated tumor cell biology and the niches associated with that. Folks interested in that study that's being run at Fred Hutch. There's Pallavi, which is one of these new 2PCR studies worked by Lou Chodos at UPenn, and our local PI is Rachel Young. And they're interested in using hydroxychloroquine or avelumab with palbociclib to prevent breast cancer recurrence. And Nora Desis and Will Wynn at the UW Cancer Institute, Vaccine Institute, have developed this StemVac vaccine to look at prevention of TNBC recurrence. So folks in the Seattle area and Washington State area interested certainly can contact our intake office for if you're interested in one of these trials. I also want to focus on that there's things that are not related to drugs or clinical trials that could be useful for thinking about metastasis prevention. And I think where we are today is that, you got to think about what is letting the cancer cells grow and colonize a distant organ. Well, it needs fuel. It needs sugars, amino acids, vitamins. It's stimulated by the inflammatory environment around it. Stress responses, stress like glucocorticoids, steroids that can help the cancer cells grow. And there's a variety of sort of mutagens that allow cancer cells to adapt to their environments. And so how does it translate to the macro? It's like, what do we suggest? It's like exercise, healthy diet, weight loss, avoiding obesity. These are things that are actually both better for your health, but also fundamentally are creating an environment that will help limit cancer cells from growing out in distant organs. I would say that, folks sometimes take vitamins and antioxidants and supplements, but there's a variety of studies that suggest not only these can impair the ability of your chemotherapy or other drugs from working, but also might stimulate cancer cells to spread and grow. So you really have to be careful about what you take in. Think about that wisely, okay? Avoiding smoking, less alcohol, avoiding mutagens. These are things that are helpful as well. And stress reduction. I mean, this is a stressful thing to think about, obviously, but then maintaining and working on things that sort of reduce stress can also increase your overall health and help prevent metastasis. So I think this is where we are today. This is what I want to say close with is sort of like in the last sort of couple of minutes. My labs has been really interested for some time in trying to understand what is the root sort of factors that allow a cancer cell to spread and grow. And one of the things that we've been really interested in is this notion that cancers are actually ecosystems. They're not just individual cells like, growing in a dish, but they're actually, actually physically and chemically coupled together. They have these collected ecosystems involving interaction with the host, with microbiome, and also allowing them as a group to migrate. We and others have shown that also you can find these clumps of cells, these circulating tumor cell clusters in the blood of patients. And when we find them in our patients at Fred Hutch, these patients do far worse, have sort of early progression and mortality. And what we're learning is that on a molecular level, when you have single cells, they don't form metastases very well. It's a very sort of low probability event, as I mentioned. But by simply putting them together into small clusters, you can increase them to up to 500 times more metastatic potential. So what causes a change in that biology? Well, what we have been studying as one aspect of our research is that when you look down to the electron microscopic level, so beyond the sort of what you can see by the light, but using electron microscope, up on the upper left-hand corner here, you see there's multiple cells that forming these clusters. And when you zoom in, it turns out that there's actually physical spaces between cells which form an opportunity for intercellular communication. And these intercellular contacts, which we call nanolumen, actually harbor chemical signals produced by the tumor cells themselves that stimulate outgrowth and metastasis. And when we shut down those signals, we basically can drastically reduce the metastatic potential of breast cancer. And so one of the things that we've been really excited about, we've developed some new sort of technologies around understanding, and now for the first time completely, what are the proteins that are produced at these intercellular spaces in any sort of breast cancer patient tumor. And we're trying to understand what is this sort of collective signaling interface that is driving the outgrowth of metastasis. And so we're really excited about some of the new work that we're pushing for in this area, and we're hoping this will lead to new therapies for patients with metastatic disease. I don't have time today with about 30 seconds left, so I'm gonna wrap it up. But the main thing is that our lab is looking at different aspects of this sort of collective metastatic process. We're finding that cancer cells actually have different states. There's leading and following cells. There's sort of like as if you think about an army, there's different roles, and that's specialization of roles allows for basically a more aggressive metastasis. So we're thinking about ways to sort of alter that specialization and alter the ability of cancer cells to sort of adapt to the environments. One of the things that we've recently published on, which I haven't talked about today, but just to say is that we also discovered that cancer cells basically rely on death. When the cancer dies on the inside, forming something called necrosis, we find that is actually the source of metastatic cancer cells. And we and others in the field now are very excited about this idea that, in fact, when we see these zones of necrosis, that is where dissemination is occurring. And we're very interested in understanding how these collective interactions between cancer cells drive something called robust metastasis. So with that being said, my team, we have a large team. I got to thank my collaborators, our patient advocates that work with us. We get our funding sources. Overcoming metastasis is a team effort. It's a collective effort. It's a collective effort of all the folks here. And thank you very much for your time, and happy to take any questions.
You mentioned vitamins. Is that like during treatment, or is it later post-cancer?
I say published, yes, in both cases, both before and after, one has to think about it. Because I think
Dr. Cheung, could you please repeat the question?
Yeah, the question was like, in what context should you be thinking about how vitamins and supplements might be affecting cancer progression and metastasis, right? And basically, I say think about it across all stages. At the time of treatment is, it's the way we thought about, for instance, antioxidants and vitamins has radically changed. I think, there was a time when we just thought, well, these are things, there's a risk of mutations, and therefore we're going to suppress, oxidative formation. But the flip side here is that when tumor cells, they've already formed, they're under a lot of stress, oxidative stress. When we team with like therapy, targeted therapy, immunotherapy, they get under even more stress. And the way you protect them is by giving them things like vitamin supplements to help them grow better. So I would just say that, I know that we want to figure out ways to be empowered to take control of your own sort of cancer history and improve that. But I would say certainly talk with your physicians, think carefully about it. And, the stuff you take in, healthy diet, fruits and vegetables, whatnot, those are fine. When you take these sort of compounds that you don't know what's in it, you have to be more careful. So